Hi, my name is Horiana and together with Gloria Liescu, we'll try to find an answer to this long debate of over 10 years on which intervention is better for palliation of symptomatic malignant pleural effusion, also known as MPE. Is it the indwelling pleural catheter, IPC, or is it talc pleurodesis? With the indwelling pleural catheter, the patients are treated with a catheter. It is a same-day procedure, and the patients can drain their pleural effusion at home, as opposed to talc pleurodesis, in which the patient is admitted to the hospital and talc is sprayed in the pleural catheter to achieve pleurodesis. We all know that no intervention has been shown to improve survival in patients with malignant pleural effusion. Hence, the management of malignant pleural effusion focuses on palliation of symptoms. Now, ideally, the management for malignant pleural effusion would provide long-term relief of patient symptoms and distress, have limited side effects, improve quality of life, be well tolerated and minimally invasive, incur low healthcare costs, and be delivered on outpatient basis. However, up to date, there are only two main management strategies, which are talc pleurodesis and indwelling pleural catheters. So I will review the pros and cons of each procedure. So here we can see in green box the pros of indwelling pleural catheters. And we can see that indwelling pleural catheters relieve dyspnea, and by relieving dyspnea, they optimize patient function. They eliminate hospitalization because they are same-day procedure, and the patient care is provided at home. But of course, the cons, being a catheter, these catheters are prone to infection. There is some procedure-related pain during the placement. These catheters can also get blocked, and sometimes they develop loculation, so the fluid becomes pocketed. Now, in terms of talc pleurodesis, the same thing, relieves dyspnea, and by relieving dyspnea, optimizes patient function. However, with talc, there is a big difference. There is always need for hospitalization. There is some procedural-related pain, and there is a very low risk of respiratory failure, about 1%. However, when that happens, the respiratory failure is severe, requires mechanical ventilation and intensive care. So how do they compare in terms of relieving the dyspnea and procedural pain? We know that from patient's perspective, symptom control and quality of life are the most important. So what a patient wishes for is relief of dyspnea, so he or she can breathe better with minimal procedural pain. So what does the data say in terms of IPC and talc pleurodesis when it comes to dyspnea and procedural pain? So this is the largest randomized controlled trial, ×2 trial that was published in 2012. And basically, patients were randomized to an indwelling pleural catheter or talc pleurodesis. And the authors evaluated dyspnea score on a visual analog scale at 42 days. And also they evaluated chest pain. And actually you can see that in terms of dyspnea and chest pain, there was absolutely no difference between indwelling pleural catheter and talc pleurodesis. So how do they compare in terms of hospital stay and cost? So in this study, the authors looked at the median time hospital stay in patients with an indwelling catheter and talc pleurodesis. And you can see that with an indwelling pleural catheters, the patients spend less than a day in a hospital, while with talc pleurodesis, the patients spend 4 days, median of 4 days, for a difference of minus 3.5 days, which is statistically significant. And in this other study, in which the primary outcome was again effusion-related hospital stay, but in addition, the authors also looked at all-cause hospital stay, which was very interesting. And you can actually see that even for the all-cause hospital stay, patients with an indwelling catheter had a median stay of 10 days versus 12 days, which again was statistically significant. And with effusion-related hospital stay, the same findings with the other study, a median of 1 day for indwelling pleural catheter compared with a median of 4 days for the talc pleurodesis, which was again statistically significant. And what about the cost? There is no difference. And even though talc is more costly initially because of the hospital cost, the IPC cost actually accumulates over time because of the supplies. So there is actually no difference overall. So I'm going to hand it over to Dr. Iliescu so she can actually summarize our data.
To summarize the data, we use stars to rate the variables. We can see that dyspnea and quality of life received 3 stars. Both indwelling pulmonary catheters and talc pleurodesis are equally effective. Cost was the same. Duration of hospitalization was less with IPC. Then why the debate? It ultimately comes to having a catheter for a few weeks with daily drainage versus hospitalization. Patients in their last days of life may prefer to spend it with a family and opt to have the catheter rather than being in the hospital. But the catheter means daily drainage. So how can we help them decide? If the patient has great performance status and great lung re-expansion, the decision is easy. Both options should be offered to the patient. If the patient doesn't want to spend any of his remaining days hospitalized, then IPC is best. In patients with limited support at home, or if daily drainage is a burden, then talc pleurodesis may be the preferred option. If the patient has poor performance status, is bedridden, or on oxygen supplementation, and if lung re-expansion is poor, we would only offer IPC, as usually talc would not work in patients with no lung re-expansion. Similarly, in someone with poor performance status with only days or weeks to live, probably talc is not the best option due to the need for hospitalization. In conclusion, individualized care is the answer. Relief of dyspnea remains the primary objective for most patients. Ideally, therapy should minimize discomfort, pain, and limit hospitalization time in patients with often limited lifespan. Both indwelling pleural catheter and pleurodesis provided comparable symptomatic benefits. However, always talk with the patient and explain both options. Ultimately, the decision is being made based on our recommendations and patient's preference.